So I think the most important diagnostic tool in Waldenström's nowadays is still a bone marrow biopsy, because we need a histological proof, let's say, of a lymphoplasmacytic infiltration in the bone marrow. However, we also acknowledge that bone marrow aspirates can be really helpful, because we can see the infiltration of mature lymphocytes in the bone marrow and also the lymphoplasmacytoid cells. And after the histological proof of the disease, we can also use the bone marrow aspirate to perform flow cytometry studies. And what we need to do with those with the flow cytometry data is to confirm the expression of certain antigens that we believe belong or are more associated to a Waldenström's phenotype. Those two are really important, and I think most centers are doing it now. And there is an extra part in the diagnostic tool that is the genomic analysis. And the one that is highly recommended now is the MYD88 somatic mutation testing. So it is a specific single nucleotide variant that we see, and we can assess this mutation by performing allele-specific PCR or droplet digital PCR. We can also use Sanger sequencing or whole exome sequencing and other techniques, but the most important and widely available are the PCR-based tests. We can also test for CXCR4 mutations. However, we know that testing these mutations are sometimes challenging, and we may need high throughput techniques that are not available in some centers. And there is a fourth diagnostic tool that is very important, and is the FISH study that we do on selected tumor B cells to see, for example, deletion of 6q, that is a very prognostic important marker in Waldenström's disease. Analyzing the whole genome of Waldenström patients is, I think, very important and crucial, and the data that was generated probably 10 years ago has now an impact, because now we are looking at not only the MYD88 somatic mutation, but also these second most frequent mutations involving the CXCR4 gene. There are nonsense frameshift mutations. However, we now know that nonsense CXCR4 mutations are the most pathogenic. And this can be translated also in categorizing the risk of asymptomatic patients like IgM MGUS and AWM patients, and also in patients that are or will need treatment. They can also, so genomics is a very important part in the diagnostic part of Waldenström Macroglobulinemia, and in fact we can see, for example, mutations in the MYD88 gene. The MYD88 L265P somatic mutation is truly important, but also mutations involving other lymphoma driver genes like CXCR4, nonsense or frameshift mutations, and alterations involving copy number variants like deletion of 6q or gain of 6p, and other chromosomal alterations that we know previously that they can increase the risk of progression or refractoriness to Waldenström macroglobulinemia.